I think it's silly to have silly. But silly is self-induced lung injury. Obviously, from the patient. And these are my conflict of interest. And as you can see, they might be part of my presentation somehow, but they will not influence the presentation. So a few years ago, Laurent Brochard, Arthur Zlatsky, and myself, we wrote a paper on the beneficial effect of mechanical ventilation, because you know that mechanical ventilation is considered to be just a vital support, but not a cure, not supposed to influence the evolution of the disease. But as a matter of fact, we think it does, and I'd show you that in some conditions, mechanical ventilation might improve the evolution of the disease, or at least stop its progression or contain its progression. So, in a way, I am going to tell you that spontaneous breathing activity is not always very good. And the initial idea comes from this study, from the lab of Ted Kolobo, one of my most important mentors. He showed that if you induce hyperventilation in a normal sheep, the sheep will get, under certain conditions, ARDS, just by hyperventilating. Then, in 2016, my friend Giacomo Bellani and John Laffey and the society, in our society, sponsored a study on ARDS all over the world. We studied 500 ICUs, 3,000 patients with ARDS. Some of them underwent non-invasive ventilation, that is, pressure support, non-invasively, before getting most of them to invasive ventilation. And the fact is that when PO2 FiO2 was lower than 150, mortality was higher in the patients ventilated non-invasively. Wow. We thought that non-invasive ventilation was always a better choice than invasive whenever we can. But if we look at respiratory ratio, we see that respiratory rate was higher in non-invasive patients. Obviously, peak was lower, but we talk about that later. Tidal volume was higher. Minute ventilation was much higher, almost 13 to 14 liters per minute, which is 3 to 4 times the ventilation of a healthy person. So, what's wrong here? I don't know yet. But if we look at PCO2 as an example, in invasively ventilated patients, we see that the most severe patients being ventilated by the physician has been reading the book, they have higher PCO2. It's called, in the old times, it was called hypermissive hypercapnia to avoid ventilator-induced lung injury. So the most severe patients have higher PCO2 while we try to contain the damage of mechanical ventilation. Unfortunately, in gray, when the ventilation is driven by the patient did not read the book. And the more severe patients have the lower PCO2. The opposite of what we, having read the book, do. Should we give books to the patient? So non-invasive ventilation was used in 15% of the patients. In the patients with PO2 FiO2 lower than 150, non-invasive ventilation appeared to be associated to higher mortality. Very soft statement, I must say. But sometimes the dangers are not in view. It's like an iceberg. Something you can see, the big part of it you cannot see. And then you sink because you don't see. And the fact here is that we see the airway pressure during assisted breathing, but we don't see what's below, the depression that the patient himself builds inside the chest. And the total pressure acting on the lung is the sum of what we see and of what we do not see. That is the esophageal pressure drop that is made by the muscles of the patient. So transpulmonary pressure in patients spontaneously or assisted breathing are very high in patients with high drive, like patients with ARDS are. Here, with my friend Giacomo as the first name in this paper, and we compared the airway pressure at the same tidal volume during pressure support with different levels of pressure support, from very high, almost controlled mechanical ventilation, to very low levels of support, almost CPAP. And obviously the airway pressure goes down. But the transpulmonary pressure is the same. The pressure acting on the lung is the same. If we have the same lung, the compliance of the lung is the same. For the same tidal volume, the transpulmonary pressure must be the same. I did not want to do this study because it was enough to read the book. Books are made to be read. Sometimes you have blue books, but anyway. And so I thought no journal would accept this paper, so obvious. But they did. It was accepted on the American Journal of Respiratory and Critical Care Medicine. This is a paper by Carteau from Paris. And you see that in patients in pressure support, non-invasively, patients with high tidal volume failed non-invasive ventilation much more often than patients with low tidal volumes. Does it mean anything? Well, please, this is a difficult slide. I took it from Giacomo once again. But these are the data from Carteau. Now, there's no pointer, actually. But anyway, you see that PEEP is 5, and the airway pressure is 7.5, higher than PEEP plateau. So the plateau pressure, peak inspiratory pressure, plateau pressure is almost 13 centimeters of water in non-invasive ventilation. Very low value. No risk of ventilator-induced lung injury, right? But tidal volume was 750 milliliters. Since compliance of these patients was 27 milliliters per centimeters of water, it means that the driving pressure acting on the lung was 27 centimeters of water. And the plateau pressure, the the elastic recoil pressure of the lung, of the respiratory system, was 32 centimeters of water. If you add the effort of the patient to what you see on the ventilator, the plateau is no longer 13 centimeters of water, but is 32 centimeters of water. And that is the cause, the possible cause of ventilator-induced lung injury. So the transpulmonary pressure in patients with spontaneous breathing activity might be, and normally is, higher, sometimes much higher, than what we see on the airway pressure. And we know that under most conditions, you can get pulmonary edema when the patient makes very negative pressures in the chest, like when we have acute airway obstruction, or when we have asthma in young patients, as an example. And actually, I thought that I removed this one, but anyway, since it's here, when in the, 23, 24 years ago, when most of you were babies, they did a study that is called the ARDS study, comparing 6 milliliters per kilo to 9 milliliters per kilo. And this, from Khaled, he noticed that when he moved patients undergoing volume control from 9 milliliters per kilo to 6 milliliters per kilo, these patients were desperate for volume, and they were making assist ventilation. They were making negative pressure to get more volume from the ventilator that was not giving them. And so these patients got into pulmonary edema, sometimes hemorrhagic pulmonary edema, just by making a strong effort to go from 6 to 9 milliliters per kilo. And actually, negative intrathoracic pressure is a model for experimental acute pulmonary edema and the ARDS. But let's skip the point of the muscles working to generate the pressure that we normally generate just by the ventilator. Now take a look at alveolar pressure. Alveolar pressure is normally lower than airway pressure because the air has to go from the mouth to the alveoli. And to move the air, we need a pressure drop. So the pressure in the alveoli is normally lower than the airway pressures. This is controlled mechanical ventilation. On the bottom line, you see the bottom line. In the line at the bottom, you see the alveolar pressure. During controlled mechanical ventilation, alveolar pressure is always higher than PEEP. Is always higher than end expiratory pressure. Normally is always higher than 0. If you have a pressure support slightly high, you have a significant drop of alveolar pressure below PEEP during inspiration. In CPAP, low pressure support, for most of the inspiratory time, the alveolar pressure is lower than PEEP. And if PEEP is needed in those alveoli do not see PEEP during inspiration. And this concept is very important. During controlled mechanical ventilation, alveolar pressure is always higher than PEEP. During assisted ventilation, the alveolar pressure drops below PEEP. And the interstitial pressure follows strictly the alveolar pressure. High alveolar pressure, high interstitial pressure. Low alveolar pressure, low interstitial pressure. Where does the edema come from? From the difference between the intravascular and the interstitial pressure. And these lungs are leaky, so they lose a lot of fluid. This is an experiment from Toronto, from Yoshida, sorry. And you see mild lung injury. And with mild lung injury in rabbits, spontaneous breathing is better than mechanical ventilation. But with severe lung injury, mechanical ventilation is better than spontaneous ventilation because the effort of the animal makes the ventilator-induced lung injury worse. In severe ARDS, the respiratory drive is not controlled by blood gases. Sorry. In severe ARDS, the respiratory drive is not controlled by the gases. You can have a patient on ECMO with 30 of PCO2, 7.5 pH, and he breathes 35 times per minute. And the transpulmonary pressure is 35 centimeters of water. And the only solution that I know is either to sedate the patient very heavily or sometimes sedate and paralyze. Otherwise, he will keep doing 35 centimeters of water transpulmonary pressure 35 times per minute. And we make ECMO to limit the risk of ventilator-induced lung injury. This is what? Oh, this is COVID-19, because the title was Patient Self-Induced Lung Injury in COVID-19. I forgot about COVID-19. But patients with COVID-19 have ARDS, at least the patients we see. And most of them have a lot of microvascular pulmonary occlusions, sometimes even not more than microvascular. Anyway, they have diffuse, important microvascular occlusion of the lung. ARDS, indeed, all ARDS is defined as a vascular disease of the lung. It has been shown in the 80s by the Boston people, by Warren Zeppel, Reginald Green. Showing that pulmonary hypertension is a characteristic of ARDS. And we, with mechanical ventilation, make it even worse. And now I'm going to tell you something that has to do with microvascular occlusion. And therefore it has to do, I think, with COVID-19. Hypoperfusion of the lung is not good for the lung. The worst hypoperfusion is right to left bypass, total right to left bypass, and makes zero pulmonary blood flow. And so if in this experiment, if you keep ventilating in non-perfused lung, you get hemorrhagic ARDS. But this was shown in 1960, what was it, 69? Let's skip the point of CO2. We are not talking about that today. But the Edmonds tied off a pulmonary artery, and he got hemorrhagic edema by keep ventilating the lung. And we did the same in pigs, and we got the same. Skip this one because it's late. And you see that when we ligate an artery of the left lung, as an example, the right lung gets sick too. And that is because most of the ventilation gets redirected to the right lung. So we have an ischemic damage one side, or at least a damage directly connected with the ligation on one side. And on the other side, we double the ventilation because it's redirected by bronchoconstriction. And so we have vascular-induced lung injury, vascular ventilator-induced lung injury, or ventilation-induced lung injury. So microvascular occlusion influences the risk of ventilator-induced lung injury because the lung itself first redirects ventilation. And then when the bronchoconstriction fades, we or the patient are compelled to increase the ventilation. These are patients with COVID-19, just to stay with the COVID-19 problem. And we have patients with high compliance or low compliance, patients with high microvascular occlusion or little microvascular occlusion. And here you see that there is a net difference in mortality between patients with microvascular occlusion measured by fibrin degradation product compared to the other three. There is no difference in mortality, high compliance or low compliance. What is important here in these patients is the microvascular occlusion. So ventilator-induced lung injury is probably ventilation-induced lung injury, spontaneous or by machine. And we have to measure what the patient is doing. And you know how to do that. It's easy. PO1 is very easy to do. Esophageal pressure can be measured today. And we have to stop this circle, the vicious circle between microvascular occlusion injury that induces in the patient an initial capillary leak, interstitial lung edema, the respiratory drive increases, the patient breathes more and more, and does patient self-inflicted lung injury. Where is it? Here. So what does mechanical ventilation? When applied at the right time, it might stop this stop. Take care of this vicious circle. Sometimes spontaneous breathing is more dangerous than mechanical ventilation.